Good.
Yep, we're good.
Okay, we're going to talk about ECMO. This is our device, McKay Cardio Help. It's not going. Oh, nice.
There we go.
Extracorporeal membrane oxygenation, excuse me, is an intensive therapy. It's not a curative therapy. It's not going to fix an underlying insult. It's not going to fix your ARDS. It's not going to fix your cardiac shock. All this is going to do is buy us time. With COVID, it would have been very helpful to have this going earlier, but it is what it is. We could run this today if need be. We never had an official go live, but we could run it. We have ran it twice in CVU. There's two types of ECMO. There's VV ECMO, venous, and VA, arterial. VV just provides support to the respiratory system and indirect support to the cardiothoracic or cardiovascular system. And VA provides support directly to both. ECLS or ECPR is something that institutions that have a very well established ECMO program could do. You could cannulate under compression and transition to the device to provide flow. That's not something we're going to do here. We have tried it. It did not work well. We tried it 20 minutes into a failing code. It did not work well. But some institutions are doing that. And I think France, there's a picture going around on the internet of them cannulating a subway station. Minnesota, they're cannulating if the arrest happens, I think 30 or 60 minutes, 30 minutes outside of the hospital. So they're cannulating in the field. So it is possible. It's something that we could potentially get to someday. It started with pediatrics in 1972. Dr. Bartlett started it then with a 2-year-old pediatric patient. Esperanza is her name. She was on ECMO for, I think, 36 hours. Bypass has been going on since, I think, 1953. But this did start with pediatrics. ECMO is going to be managed in CVU or ICU. The device doesn't take up a ton of space, but if we're on this support, we can transition to CRT with this, and we can transition to an Impella in addition to. If you're on VA ECMO and you need to unload the left ventricle, we can use an Impella as well. So the device does not take up a lot of room, but it can get quite cumbersome if you start adding on different equipment, CRT, Impella, the patient's cells. It could take up a lot of room. It's going to be managed by the cardiothoracic surgery right now is going to be the one cannulating. Perfusion, the intensivist, and then there's going to be an ECMO specialist. We have 12 trained nurses to set pump, in addition to an intensive care nurse, the respiratory therapist, and interventional cardiology and nephrology may be involved as well with CRT or an Impella or a left ventricular assist device. There's several inclusion/exclusion criteria for who's going to be a candidate for ECMO or ECLS. I don't know if Shanna put that in the PowerPoint, but it can get quite cumbersome. Ultimately, it's going to be up to the providers if they think the patient's a candidate or not. What are contraindications that we could overcome, and we'll go forward from there. ARDS is going to be the popular reason to cannulate with our population, especially with COVID. There were several people that we could have cannulated early, but they sat on the vent for 5-6 days on high tidal volumes, high PEEP, and caused lung trauma that could have been reduced if we would have started venous ECMO. Here's several other reasons, to cannulate: cardiac support, ARDS, cardiac shock, cardiac arrest. bridge to VAD or bridge to transplant. So a lot of these patients, we're not going to keep in-house. We're going to transport them to a tertiary center that can do VADs or transplants. But that brings up a good point on transportation. Those are going to go by air, and we're still trying to figure that out. They can't take, bless you, they can't take these pumps by air with Airvac.
They can, or they're too big?
They can take them. Yes, they can. But that brings the question of how are we going to get staff to sit pump in transit? I don't think we've trained, well, I know we haven't trained any Airvac nurses how to manage the pump. There's 12 RNs from ICU and CVU that have been trained to set pumps. So there's kind of an issue there.
Right? I mean, you've done it before in the past.
Yeah. Mm-hmm.
They could go, I mean, I'm sure they're cheap on the state commission, they can't go that fast.
Yeah, it's a 2-hour transfer with a lot of support.
It was a lot.
General contraindications, malignancy. I mean, if you have a terminal illness, the risk factors, it's not in your favor. Immunosuppression, irreversible injury. Like I said, this device is not going to cure anybody. It's not going to cure any disease differential. It's just going to buy you time. Cannulation can occur at the bedside and ICU, CVU, the OR, ideally, or the cardiac cath lab. There's several different ways to cannulate, several different locations. It depends on the type of support, the size cannula, the size of vessels. Cannulas range in size drastically from 13 to 31 French, depending upon what type of support. And that's going to come down to a perfusionist and CT discussion, what kind of support or what kind of cannulation strategy they want to use. But as far as options, you can do IJ with a single lumen or a single cannula, dual lumen option for VV ECMO. But those have to be done under fluoro. You can do venal or femoral artery, femoral vein, or if your patient's been in the CVOR, you can do a direct cannulation or central cannulation to the aorta and or the right atrium and the inferior vena cava. So you could run central ECMO. There's an image for a dual lumen Avalon cannula. And yeah, the chest tube's 32 French. We can get up to a chest tube size cannula. So obviously a huge, I think we get into risks here in a minute, but a huge risk can be bleeding. These folks can be heavily anticoagulated. And this is the image for cannulation with the dual lumen, and this is why placement is such a particular issue. You have to have that outflow track to the mitral valve. And here's a femoral cannulation. So the differences between venal arterial and venal venous ECMO. Venal arterial or VA ECMO provides direct cardiac support, bypasses heart and lung, could be used for right ventricular failure, low perfusion, yada, yada. And VA is for specifically respiratory support. You do get some indirect cardiac support, but that's negligible. There's a couple different kinds of consoles. You can have centrifuge, which is what this is, or you can have a roller pump, and that's very similar to our CRT pumps. That has a higher risk of hemolysis. And this is the cardiac or cardio help in use. It does have a backup battery. I don't know how long, I think it's 8 hours. The device itself, here's the pump, and each patient will have their own set that they're on, and here is the for the membrane oxygenator itself. Sweep gas. There's that. And this is kind of interesting. The VA mixing cloud. So there's a complication specifically for VA ECMO called Harlequin syndrome or north-south syndrome. That is a result of that mixing cloud. When your left ventricle starts to regain efficiency and start pumping, it's going to pump against your ECMO flow. So what you're going to have is a deoxygenated upper torso and an oxygenated lower torso. It's specific to ECMO, specifically with femoral cannulation. It's kind of neat. If you look up photos, you can actually see it in the patient's color. So to prevent that, you're going to reduce your flow of ECMO and do more routine echoes to look at your left ventricular EF. Complications. Bleeding is going to be the big one. All these patients are going to be on a copious amount of heparin. If they develop HIT, we'll switch to a direct thrombin inhibitor, or Gatraban will be the drug of choice. We're going to be using an anti-factor 10A, which we can start running in-house. And we also have a HIT panel in-house now. That's a result to ECMO. Hemolysis will occur. Pump failure can occur. If pump failure does occur, we do have this nice handy hand crank, which is very fatiguing. Air embolism, when priming that pump, it's very particular to be free of air if air does enter, because you can push medications through this. You can draw your labs from this. You can tie in your CRT through this. So there is option or opportunity to have air enter the circuit. You can get it out, but that is an emergency. And decannulation is an emergency. According to the extracorporeal life support 5th edition textbook, if you decannulate the VV ECMO, you can apply pressure and prevent exsanguination. But for VA ECMO, you have to go to OR and repair that vessel. Assessing neuros is going to be complicated for these folks because in contradiction to Dr. Rippleman's lecture, you're going to want these folks down because of the risk for pulling something. I mean, a garden hose or a chest tube is what we have in the femoral artery on a copious amount of heparin. I think our target ranges are a little more thin in comparison to CRT or Impella. So hemodynamic changes, that's something else that's kind of interesting. When you go on support, you're going to reduce your hemodynamic. Yeah. Yeah. Oh, yeah, absolutely. I don't know where I'm kind of buzzing through this, but so when you go on support, you're going to take note of your ventilator settings prior to going on support, right? And you're going to write those down, keep them on the vent, and they're going to remain on the ventilator. If we were to have issues or an emergency, you're going to resume those emergency ventilator settings. But once we go on support, I'm providing oxygenation through the device. So you're going to have what we call rest settings, you're going to reduce tidal volumes, you're going to reduce your oxygen, you're going to reduce the device is oxygenating the patient. Same thing with your drugs, your inotropes, vasopressors, vasodilators. I'm doing all of that through the pump. It'll tell me my cardiac output on the pump. I mean, you're going to have some native flow. For VA ECMO, if you have an art line, it should go close to flat. I'm doing everything. And that brings up another good thing or conversation. If they code on VA ECMO, it is an emergency, but I'm oxygenating and perfusing that patient. I don't have to do CPR. VV ECMO, you do, because we're not providing direct cardiac support, but in VA ECMO, you just have to get them out of the arrhythmia. So it is an emergency, but it's not, you're not doing compressions. You're providing support through the device.
You need to take a timer to take care of your drugs.
Yeah. I mean, even epi, why? I'm doing that. Well, why? Why do I need epi? If it's VFib, shock them. If it's amiodarone, whatever. Yeah. Yeah, you treat the arrhythmia for V, and that's specifically VV or VA, excuse me. If they're on VV, I mean, you have to code them like normal. In fact, you should bag them as opposed to oxygenate through this. But for VA, I mean, you're doing all of it through the pump. You just got to get them out of the arrhythmia.
So VV is mainly respiratory.
Yes. VV is just respiratory. VA is cardiopulmonary. Yep. Yeah, absolutely. COVID. And I think we'll see a lot more VV here than we will VA. Specifically, we have no way to escalate care for VA. We don't do LVADs here. We don't do transplants. So they're going to have to go. Now, we're probably going to have them for a day or two, stabilize them to a point where we can transport. But once they're on, I mean, we can't escalate care. So I think the majority of patients that we run would be VV. But I personally look forward to VA just because I enjoy cardiac. So with weaning the vent, you're going to wean your hemodynamics, and ideally you shouldn't be on any vasoactive drugs. I can just adjust the RPM of the device and correct that. Here's a slide on the medical emergencies for VV and VA. So VV, we're going to bag the patient, utilize ACLS. VA, we're going to bag the patient only. CPR is not necessary because we're providing hemodynamic support through the pump. Weaning with VV, you're going to reduce the oxygen support through the device, turn off the sweep gas, and closely monitor PaCO2, SpO2. We're going to try to do a successful wean is an FiO2 of 60% or less. And VA is a little more rigid. We'll slowly reduce the sweep gas and the flow and do pretty frequent echoes. Look at that left ventricular function. Look at our EF. And decannulation ideally will be done in the OR. So patient management, we can, yeah, they might have to do vessel repair, patch or, yeah, it'll be Arnold. Mm-hmm. They'll go probably back to the regular vent setting, or ideally a reduced setting from what they were prior to. Ideally, we would have treated that issue, that underlying insult, to a point where they don't need the high vent settings that they were on prior to going to support. No, not yet. Right. After we get the cannulas out, we probably reduce the sedation and get back towards, what Dr. Riddleman's wanting, pain focused. Like I said earlier, we can run CRT through this. You do not have to put in a trialysis catheter. I can run that through the device. I can get gases through the device. I can draw labs from the device, and I can push meds through the device. But all of that requires a lot of forethought on whoever's priming the pump, because you can add multiple pigtails to several portions of the device to allow you access to do those things. Just talks about the rest settings, knowing our emergency vent settings. Those are those pre-ECMO vent settings. In summary, ECMO can save a life, and it's a team effort. I think that's the biggest thing to take away from this. I mean, there's going to be several people involved. You're going to have, the plethora of physicians. We're going to have, the ECMO specialist, critical care RN, RTs, PT, OT, techs. We all need to work together and discuss every little detail with one another, because what I do to the pumps directly going to affect what you assess, and what you give as far as medications is going to affect flow. Turning these patients is going to be an event. Just working together is going to be a huge thing, and proper patient selection is going to be a huge thing as well. Depending on what book you read, the survival rate of people that have ECMO is around 50%, but 50.
That's if it's initiated early.
That's if it's initiated early. Yeah. Yeah. But if you think about it, 100% of those are going to die if you don't.
Right.
I mean, the mortality rate that would be required, so to speak, to warrant this is about 80%. So if you're sick enough to get this device, I mean, there's a high likelihood you're going to expire anyway. So if you can save half of them, that's great. So 2 days. So the patient that was in room 11 that we sent down to Barnes for ECMO, the night Taylor intubated, we were on by event at 100%. We should have been talking about it the next day. If we're using high tidal volumes, high PEEP, putting that kind of stress on those lungs, we should be discussing this early. And we should have, CT surgery consulted. We should have the intensivist consulted, depending on if it's a cardiac patient, cardiology, and making that decision together, mainly the physicians, which that's a chore in its own, having all those personalities. And doing that during the day. We don't want to be, well, I'm not wrong. Right. Yeah. 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 So the multiple meetings that we've been in with, we hired a third-party consultant company to help build this program. They are the ones that came through and taught all the bedside nursing staff how to run the device, and the physicians as well. So in the multiple meetings that we had with all these people and putting all those physicians in a room together, the conversation at the end of the day is you just need to consult CT surgery. They'll look at it together, discuss it, and move forward or not, depending on patient condition. But we need to be having those discussions earlier.
Yeah. We had to go to a patient in ICU that was COVID, and she was a large lady.
Was she in like 6?
No,
or
I'm thinking of some 4.
4? Okay.
4, and I overheard the doctor's conversation because they were trying to get her somewhere.
Mm-hmm.
Then they got a hold of Iowa City.
Mm-hmm.
Iowa City told them they would not take her because they said because of her size,
Mm-hmm.
they said they do not have good outcomes and they wouldn't even take.
Yep. So. Yep.
But, and I just want to.
Resource heavy.
Mm-hmm.
It's extremely resource heavy. So
Okay.
if you don't have, the criteria is a little tighter, I think, during COVID.
Okay.
If there was if there was
There's a
maybe-
BMI cutoff too. I can't remember specifically what it is. I think it's 45. Mhm. Mhm.
Like, I don't like, feeling like Robbie, like, Shannon, I keep pushing through this because they're doing the units are hired to it, or they really need to get the, learn a lot from her kids who didn't know that about everything I think they asked me, they feel that a lot. And then she did on Friday to her, they're like, illness and then even like after they're like, their own day, they can say, hey, no, we're back. That's why we got the 48 hours. And then if you don't try it, there's the second. The big thing, like I want, and I think all the things they've been already about, is it's just gonna be different looking for advocating for the patient and the ECMO nursing and you know, helping us like being able to make that, you know, people who are used to really managing the whole bit, and the nurse is feeling like, and they're studying and then take them out, you know, see this big patient and not understand what's going to be in a so just really like education and training and or the doctor, and that's not normal, right? And normally it's like in the room and press and tell them like, okay, so I think it's just gonna be a different, like I said, like the lights and the different. And like there's things that look like not really also those kind of stuff like there's the stuff that's and they already have set up.
Did you already put it on the YouTube?
They do not, since they are a highly paid company, they offer their services. They help us develop policies. They help us develop order sets. They helped us develop our bedside handbook. But unfortunately, no, they do not even share their PowerPoints and stuff with us. That's it's copyrighted. I don't even want to know how much they make to do the things they do, which they are, I mean, they're brilliant at what they do. I mean, they even fly around to, I mean, they may fly across the country just to run ECMO somewhere at a hospital because they don't have specialists. We don't have that luxury. We don't have enough money to do that here. We cannot pay them thousands and thousands of dollars a day to just come and run ECMO. So that was why we had them train us how to do it. But no, unfortunately, we do not have their resources, but also they're the ECMO gods. They're the governing bodies of ECMO. That's how DNB and JCO actually, when you get surveyed for ECMO or to actually like have, you know, how, you know, we're a stroke center or a chest pain center, to be an ECMO center, you know, for us to get surveyed by DNB and them allocate that to us, it's all ELSO guidelines. So we have more of these red ELSO books. I mean, if anybody wants to take one of those, and ELSO. Yep.
Corporeal Life Support Organization.
So if you look up ELSO, that is where you will find everything. That is where our policy is derived from. That is where Innovative ECMO Concepts comes up with all of their education, and all is derived from ELSO and their guidelines. So they do provide, I mean, part of this PowerPoint I pulled from them and the AACN. There's also stuff on the AACN for nursing specific. If you want to look up that, I'm not sure. I know RTs, you have, I won't say governing body, but you have an organization that probably has quite a bit of information on it too. So when we go to, we're going to be running ECMO here. I say when we run ECMO here, in the sense that after all we've done to build this program, it is, you're going to have the specialist that sits pump. I would imagine you guys as the RTs, I mean, it's going to be whoever is in the ICU, and you're going to be heavily involved with that patient pretty constantly. And then you're also going to have that bedside nurse. So really you have two nurses plus an RT and then plus your intensivist. So that's, and then, yeah.
It's really a 2-to-1.
It is.
Real, truly.
It is.
Because really you have a nurse, or, I mean, that doesn't have to be in other institutions. You know, RTs will sit pump, you know, physicians will sit pump. It's whatever. We built it, honestly, because nursing built the program. So we train nursing first. Down the road, that may look different. We may have RTs sitting pump, but we need our RTs to manage all the other aspects that we don't normally manage every day. So we have ECMO specialists on call that are going to come in to run pump. And then the bedside nurse will take the patient. We may switch up assignments, and that's going to be completely up to leadership. That's going to be up to Rick, Beth, Laura, Robbie on how that works, especially when we go through these first cases. Will that mean that somebody else that's an ECMO specialist, maybe that's here taking care of a different assignment, may go ahead and take care of that patient as the bedside nurse? And, you know, Robbie's going to sit pump. We may do that. That just, it kind of depends on the patient. It depends on what else is going on everywhere else. But yes, Claudia, you're right. It's for right now, it's going to end up being a 2-to-1 plus RT plus, you know, our intensivist plus Dr. Arnold. And then, you know, once we get our next CT surgeon coming soon, Larry Coster, our perfusionist, and it'll be a big team effort. And probably any changes we make, any decisions that are going to be made are going to be a team effort. You know, it's going to.
I just was imagining the room, and I can't see one nurse in that room. You know, I'm like, this room is going to be.
I think
Right. That's kind of the plan, Amy, because CVU has so much more room. And that means we may just have to switch out what we're doing. That may change for you guys, you know, like, okay, we're going to swap so-and-so here because they, you know, they're a little more comfortable with this. So we're going to put them up there, and we're switching nurses around because, I mean, yeah, this is an all hands on deck type of situation.
But depending on the room, you can isolate within the department. I mean, if you put all your infectious patients in, you know, 9, 10, 12, and
Yep.
yes. Yep. Oh,
Oh, no, that's not the one I wanted to put up there, but.
mhm.
Different way of saying shit.
I'm trying to open this so I can show them.
So I'm not
Open up on here.
For the coming person.
Probably not up there either.
You have to share it.
We're for the resources. Robbie and I have read a lot of things, because I did not before them were things that were in housing. So we're getting cool. It's exciting. I'm looking at the whole building already. So I'm excited. We're going to go back and it's been really cool. Guys are doing people resources. And like if I down there, like like staffing and creation things like friends will work a little bit to do. I ready to do it. People are critical care, people them all about it, because you know, and that maybe the nurses right now have the full schedule, and they need them to give us department, which are nurse, and give the department do a lot already in the year to be extra cost for them. Some of them do that in the stress. So it's a lot on the team right now. It feels a lot of things that for me. And then Robbie with the local gaps. So if we know that though, we know how to get the up or down. I'm glad that they're taking like I do we work with them before. We can to play forward to everyone starts. It's so cool. I think it'll be a really good collaboration, really big complicated patients that we can keep doing right at the Nurses covering if I can start to go to whatever, is she gonna trouble or is she gonna come get it? Oh, just fear saying that they'll just go go.
Any other questions?
So you would be the, I'm not putting anything on, I just want to know, so you're the one that's heading this up and leading you?
I believe Beth is the ECMO coordinator.
She has unofficially been named the ECMO coordinator.
But you're on the team that knows.
Yeah, I was trained as one of those ECMO specialists, and I've read quite a bit on the subject. Yeah.
So is this program ready to go, like, we do on somebody tomorrow?
Yep.
I can do it tonight, yeah. If you find someone to do it, I'm down.
We had one we were talking about, right? There we go.
Yeah. They are- they are-
Finally, you're here.
That they had a great grant. They get me help it. They have granted for the next day. They want to do something with our retreat.
There you go.
So they don't have that, right? And then, what is that next? They have to, just considering everything emergency stuff, Anyway, so it's been cool. It's been a good collaboration across the board, providers, nursing, and a lot to start. So like a early kind of schools, kind of cool as you were going to do and get going with it. And we just need to get some cases going and get the first few months under our belt.
Some good cases.
So we know how much of a month has turned out.
The one from ICU.
Really?
Because we were talking possible ECMO with her
Did they run
yesterday,
her?
day before.
No.
Is that what you're,
No, room 11. Oh, shit.
sorry, I thought you were talking about, because there was a room 11 just from the other day. Yeah. I'm like, we're already moving her out?
I have talked
They just sent on board on the second.
I need to go.
Yeah. Unfortunately, this one's broken, so I can't put fluid through it and actually run
The
it.
circuit, not the
Circuit.
machine.
Circuit.
The picture I have up here,
Are they our machines?
yes, we have purchased them.
We have two of these.
Yes.
Two of these.
The picture here is from when we did our demo.
And that's on Keys.
Yeah. It was.
And it took up, well, the whole room.
So this one, if you wanted to, you did a CRT.
We did a CRT that we ran right into.
Run
into the
CRT
device.
through here and then through an attachment here. You have your pre-oxygenator, post-oxygenator. Yes, you do.
I'm glad you wanted the phone. Okay. I see the oxygen tank on the side, so that's where they get their oxygen from, just like on a ventilator.
That's our speak gas, and your oxygen's gonna come through the hospital.
Oh, so it'll go through the actual, okay, and when you say sweet gas, what do you have?
So speak is what we're gonna use to reduce CO2. It's going to promote CO2
Okay,
that way,
okay,
as opposed to strictly just oxygenated.
okay,
So if you just.
okay.
The machine that took these cards and I get your numbers right.
Now, this perfusionist, does he have to be at the bedside 24/7?
And it depends on the organization. When they started ECMO, they started with perfusion sitting at home.
Okay,
Larry's our perfusionist who sits in CBOR.
right,
And no, he's not gonna sit in home. That'll be RN that's trained. So,
That's why we trained our in, so that we only had one perfusionist in-house.
only one.
And we have ran it before, and he did, between him and Dr. Arnold, they were here all the time. They were sleeping, I mean, they, where my office is now, they were sleeping in there, you know, so they could still be on the unit, you know, if anything happened. But we ran it one, yeah. So now we have the ability to have, you know, have one of the nurses that's trained in it to sit there and run it and be there all the time. Oh, no, this is question time. Yeah, it's like,
Okay.
Robbie's not much for like following a presentation. He
No,
would rather-
I really hated that.
I know you didn't. I could tell. I was listening to it as I was shoveling.
He was looking at this, I don't know if Shannon put this in there, but we're just gonna do it my way, so it's like, whatever.
Yes, because I'm the type A person that put together the PowerPoint, but I'm like, Robbie, you're the, absolutely. I'll send them out to everybody, actually.
Okay.
Oh, good.
Yeah.
I would love to.
That was the first thing I said. I said, I wish I had.
I will send everything from all of these presentations out along with the recordings. Now, it's always a real pain in the butt, depending on what computer you're on, if you can get the recordings from your email.
Oh,
So I will also upload them to the YouTube channel.
How do you get on the YouTube channel?
So I can send you the link for it. I put it on the Facebook page, but I know not everybody has Facebook, so I can send you guys the link. Remind me if you don't get it in the next couple of days, text me and remind me for that. That's where I put all of our providers, anybody who does presentations, I've been putting that on there. It's easier to look at from home. You can do it from your home computer or your
See,
home,
that's what I-
or your home phone, you know, rather than, because when you try to get it through the email here, there's like a firewall. It blocks you from putting in your personal information on this one. And if you try to send it to your home one, yes. And so it's difficult.
Okay.
Okay, I'm gonna stop the recording. I forgot I was still recording. No, you're fine. But if you guys want to stay on, I'll do a drawing here in just a moment.
German company, so.
Oh, maybe that's.
Yeah.